Yes, great. So welcome everyone to our final community practice seminar for the year. We're delighted to welcome Ruth Walker today from the University of York. So Ruth's a research fellow in evidence synthesis, and she's completing an NIHR doctoral fellowship. Is going to be talking today about a project exploring the use of evidence synthesis methods in child health. So thanks, Ruth, over to you.
Thanks, Jonathan. So I wanted to share some of my experiences of involving children, young people, as well as their families in my project, which has been exploring the use of evidence synthesis methods for overcoming data scarcity in child health. So I've done this, so I've applied these evidence synthesis methods in an area of child health where, in comparison to adults, evidence is known to be lacking. So the project has sort of a dual focus, both to sort of improve understanding within this particular clinical area, but through the sort of experience of applying the methods here, consider the practicalities and usefulness of applying evidence synthesis methods in child health sort of more broadly. So, structure of the talk, I'm going to give some sort of background to the project, both in terms of the evidence synthesis methods and the clinical area, and then I'll go into where the public involvement has fit in within these particular areas. So I'll sort of go through sort of the methods of the patient involvement, the outcomes, as it were, and then what kind of impact this has had on the project. So, why evidence synthesis methods in child health? Well, as sort of statisticians and methodologists, we probably know that evidence synthesis methods are used to combine and reanalyze data from primary studies addressing a specific research question. So they're often used to inform healthcare decision making, particularly when we're thinking about which treatments to recommend for a particular condition. But in the child population, evidence can often be lacking, and this is due to sort of a unique set of challenges associated with conducting research with children and young people. So there can be a lower disease incidence in children. There can sometimes be a reluctance of researchers and pharmaceutical companies to sort of take on the increased effort required to both recruit and then conduct research with children. So as an example, you might need like more centres to recruit sufficient numbers of children. Children might need different medicine formulations, so liquids instead of tablets, or smaller doses, and this can all be associated with increased costs. And then at the other end, children tend to be a smaller set of consumers, so the potential benefit for future sales is possibly not as attractive as for adults. And there's also sort of ethical issues sometimes around gaining consent from parents, primarily for children under 16, and assent from children themselves. So that's like an agreement to participate. And all of this leads to a limited evidence base in children. So we have sort of less certainty about the efficacy of health interventions in children compared to adults. And this has implications for the provision of care in this population. So treatments are often used off-label, meaning they haven't been approved by whichever sort of regulatory authority for use in that indication in children. So it's possible and does happen that in some areas children are receiving sort of suboptimal care because we don't have that evidence base supporting the use of particular interventions. So there are a number of evidence synthesis methods that can allow for the sort of borrowing of statistical strength from indirect evidence, sort of separate but related populations, as well as correlated treatment effects of outcomes. And these could help to overcome the scarcity of evidence in children and improve our understanding of which health interventions work best and for whom within the child population. And this could potentially reduce the need to conduct so many clinical trials in children, and we might get away with sort of smaller confirmatory trials with sort of applying these evidence synthesis methods. So before I go into specifically which evidence synthesis methods I applied, I'm going to introduce the clinical area because I think this is going to better demonstrate why I applied the methods that I did. So I've been working within an area of supportive care in paediatric cancer. So supportive care is really the things around the treatment of the cancer itself. So think more the sort of management of side effects. And specifically, I've been looking at antiemetic medications, so that's anti-sickness medications, for the prevention of chemotherapy-induced nausea and vomiting in children and young people. And I'll refer to this as CIMV from here on. So this area, like others in child health, has a sort of lacking evidence base in children compared to the adult population. So very briefly, so sort of prior to my project, there was an established evidence base in this area. So this is kind of where my project has come in to build on this. So there were a number of clinical trials that have compared these medicines in children, and the results have been combined, using narrative synthesis and meta-analysis. And this is what is informing the current clinical practice guidelines. This is a summary of what those clinical practice guidelines recommend. So you don't need to know the full details of this. It's just to highlight a couple of things. So firstly, these anti-sickness medicines are often given in combination with one another, and they're recommended depending on the chemotherapy that you receive. So a metagenicity refers to sort of how sick the chemotherapy would make you in the absence of prophylaxis. So this is just to highlight really that we're working within a population with quite a lot of clinical heterogeneity, both in terms of the treatments that the children are receiving, as well as the kind of individual characteristics of the children themselves. And the sort of relevance of that will hopefully become clear in a few slides' time. So the limitations of this evidence base. So firstly, meta-analysis combines evidence of studies from only 2 interventions, meaning not all antiemetics have been compared to one another. And the clinical trials that have been synthesized are often small, and we've mentioned this can lead to imprecise estimates of treatment effect, but it also limits our ability to explore treatment covariate interactions. So thinking about which children derive the most relative benefit from a particular regimen. So this is particularly hard sort of within trials. When you've already got a small trial, it's even harder to then start kind of exploring effects within subgroups. And previous syntheses have also highlighted limited patient important outcomes available, in this case nausea. So often in children you find that more sort of subjective outcomes can be less well reported because not always, but they're sort of perceived to be harder to measure, particularly in very young children. So this is a sort of example of that. So I've applied 4 particular evidence synthesis methods to overcome these specific limitations. So I've applied a network meta-analysis that allows for the comparison of 3 or more treatments simultaneously. So here we're able to compare sort of each treatment to every other and make indirect comparisons between treatments that have not been compared directly in clinical trials. So this has the advantage sometimes over meta-analysis estimates in terms of precision, because some comparisons can be informed by both direct and indirect evidence. I've then incorporated adult evidence into the networks of children. So this is done using an information sharing model, which sort of extends the network meta-analysis model to include 2 separate but related populations. And the sort of rationale for this is to see if we can borrow strength from the adult population to improve the precision of the estimates in children. This particular model was done using sort of avoiding the assumption that the populations respond the same. So instead, we've estimated differences in relative treatment effect between the populations and tried to use this to facilitate predictions of new treatments in children where only adult evidence is available. So sort of thinking about the fact that treatments are often sort of approved in adults long before they are in children because of the sort of lack of evidence in the child population. So these 2 synthesis methods use aggregate data, and the next 2 have used individual participant data. So that's the raw data that we've acquired from clinical trials. So thinking about those kind of poorly reported patient important outcomes, I've applied a multivariate synthesis to borrow strength from the better reported outcome of vomiting to improve the precision of treatment effects of nausea. And then remembering back to that sort of clinical heterogeneity in the child population, I've then applied an IPD network meta-regression to essentially assess whether individual characteristics are altering the treatment effect. So where does public involvement fit into all of this? So before I kind of go through what I did, I think it's important to say that public involvement in evidence synthesis is sort of steadily growing, despite them being often quite statistically complex projects. So there was a review done in 2018, so a little while ago now, by Pollock et al. And this showed that people are sort of being involved throughout the research process. So right from sort of setting review questions and identifying outcomes right through to dissemination. And people have done some nice things as well, where, you know, they've provided training to help people actually be involved in some of the aspects of the systematic review themselves. However, like when sort of conducting research with children, involvement in children in research can also be lacking in comparison to adults. So some recent work in research priority setting in children suggested that there was 25% of studies had sort of parental or caregiver involvement, but only 5% directly involved children. So we're not kind of getting the child's voice readily sort of coming through in these types of projects. So what have I done in my project? So I started involving people actually during the development of my grant application. So I applied for a small grant from the NIHR Research Design Service to involve people in the development of the project. So the opportunity to be involved was advertised through the sort of social media channels of these patient support charities, and that's something that I've done throughout, and they've kind of been instrumental in helping me to involve people in this project. So for this involvement, I recruited 3 parents of children who had experienced the IMV and 1 adult who had experienced the side effects himself as a child. And this helped me to better understand whether they considered the research valuable, how they would feel about being involved in particular aspects of the research, and how we could best sort of facilitate that involvement, and then how they'd like to hear about the results of the study. So this is a kind of summary of the feedback. I'm not going to go through it all, but it just gives a flavour of kind of what was implemented as a result of the feedback that was given. So it sort of informed the methods of involving older children in the evidence synthesis. So for example, holding separate meetings to their parents, because they might sort of feel influenced by the presence of parents or carers, holding the meetings online because of commitments with school. It might be more difficult for them to travel, particularly sort of during the working week. And then another kind of important takeaway was that they thought it would be best to disseminate findings using a short animation video. And this was something which I've done, but to do it, I've involved I've done it through an external company who kind of do it all professionally, and it ends up being very expensive. So it's not something that you could just sort of think, oh, I'll just do this at the end. It's something that I had to cost into my grant application right from the beginning. So had I not have identified this at this point, I don't think that that would have all been possible. And that's actually ended up being a really nice output of the project. In relation to kind of understanding the importance of the project, I think one really important part of involving the public in evidence synthesis is having a better understanding of the sort of reality of the condition that you're researching, because as like statisticians and methodologists, we're often very far removed from the kind of everyday reality. And I think this involvement helped me to understand the sort of seriousness of these side effects when they're uncontrolled, and the impact that was having on their kind of everyday lives. And then I think it helped me sort of better convey this in the grant application. So helping me to explain the importance of the project and demonstrate that in practice, this is still an issue for children, despite there being, you know, anti-sickness medicines available. So once I'd started the project, I involved people at sort of 4 key points. So identifying which outcomes matter, interpreting some key findings of the project, the creation of this animation video, and then I did some work, some sort of further work to evaluate the involvement itself. So one of the first things I did in the project was to try to identify which outcomes mattered most. And this meeting was again held online. This was primarily because it wasn't that long after COVID, and I think people hadn't really gone back to the office properly. So we decided to hold this online. We used similar recruitment methods to the previous involvement, and people who offered to be involved were sent sort of information sheet in lay language explaining more about the project and why we were doing it and what the kind of involvement would entail. So again, we recruited three parents of children and one adult who had experienced CIMV as a child. So at this stage, it might sort of become clear that we were struggling to recruit children themselves. And I'll explain a little more in a minute about how we sort of overcame that. So because this was an all adult group, we did a presentation to begin with on the project aims and methods. And so I tended to just focus more on the sort of broad concepts of what the evidence synthesis methods help us understand rather than the specifics of how the methods are conducted. So sort of getting around explaining, what is quite a statistically complex idea. And to explain the concept of outcomes within clinical trials, I actually used this existing plain language animation video, which is designed by the Comet Initiative and it's available on their YouTube channel. So there are kind of existing things out there. You don't have to kind of design everything yourself. This was a really useful tool just to get across what outcomes are and how they're measured, for example, and helped to sort of facilitate discussions around which outcomes matter most to them. So these are the outcomes which people identified to be important. So they were largely focused on sort of more quality of life and were often connected to the outcome of nausea. So even things like sleep, quality and quantity of sleep was to do with like feeling very sick in the middle of the night. So yeah, I think this kind of highlights the importance of that nausea outcome. So how did the identification of the outcomes impact the project itself? So the outcomes were sought in from the aggregate data for the network meta-analysis. And in doing so, we actually identified a lack of these patient important outcomes reported within the clinical trials. Often nausea was poorly reported and the other outcomes which I showed some of them were not reported at all. So this led to a key recommendation of the synthesis to improve reporting within the primary clinical trials and potentially develop a core outcome set which would help to standardize reporting across trials and make synthesis within the area more possible within sort of future research. I think it also gave weight to us trying to understand through the multivariate synthesis this poorly reported outcome of nausea. And we actually found within these analyses in the end that this synthesis method didn't meaningfully improve the precision of nausea, primarily due to a kind of lower than expected correlation between the treatment effects of vomiting and nausea outcomes. So it kind of gives strength to the recommendation that these patient important outcomes need to be better reported in the clinical trials of children, as there might not be a good sort of substitute for this data. And then for the treatment covariate interaction analyses, these outcomes were again requested in the IPD, and IPD can give a sort of additional opportunity to look for patient important outcomes because not all outcomes that are collected in a clinical trial are reported. So it might be that the IPD does contain some of these outcomes. We also requested some important factors that could alter treatment efficacy, for example, sort of baseline anxiety levels. But we found actually that, again, the outcomes and covariates were seldom collected. So this led to a recommendation that, as well as improving the reporting, we need to be thinking carefully about which outcomes are collected in the primary studies. Okay, so moving on to interpreting the findings. So I mentioned a few slides ago that up until this point, we'd struggled to recruit children and young people to take part. So the original plan was actually to involve younger children through involvement activities at Leeds Children's Hospital, and to hold separate meetings for older children through online meetings, thinking back to kind of that initial feedback that we got through the development of the grant application. But I think in practice, this just wasn't working. And we kind of spoke to some people who were involved in the outcome prioritization, and they thought that it was possible that children might not want to kind of return to the hospital environment outside of treatment, and older children might benefit from actually just being around people that they already know and trust. So we had quite a radical change of plans at this point. We actually approached the Candlelighters Supportive Care Research Centre. So this was established in 2023 to research sort of prevention strategies for the side effects of cancer treatment. And this group had an established PPI group, and the PPI group was originally established to sort of support the centre's projects, but we thought it could be expanded to involve other research projects, including my own. So this is what we did sort of moving forward, and it worked really well. So as part of this group, children of all ages and their families are invited to quarterly meetings at the Candlelighters building in Leeds. So there's a sort of a number of advantages to holding it here, because the centre provides the building itself is like a familiar space to people. They know the staff. The staff actually helped us to facilitate the sessions by running like icebreaker activities, and they're also experienced in sort of play-based methods for involving younger children. And at these events, you would have like a number of researchers doing short activities. So the sessions ended up being quite varied. And yeah, in terms of like kind of practicalities, different researchers who were presenting there would use their own funding. So I used, for example, my own funding when I was at the sessions to cater them and to pay people for being involved. So I use this setup to involve people to interpret some of the key findings of the project. And one of the main findings was that the combinations of anti-sickness medicines do work best to prevent CIMV, but they also come along with more side effects. So if we remember back, side effects were identified as a patient important outcome. So we wanted to know what this sort of meant in practice. So this time we were successful in involving children and young people. There were 3 children there and 5 parents. Thinking a little bit about the kind of ethics of this type of involvement, we did start by checking that everyone was kind of happy to be involved, and we made it really clear that, you know, if anybody wanted to leave at any time, that was absolutely fine, and people could choose which activities they were involved in, and there was just no sort of pressure to be involved if they didn't want to be. because it was a mixed age group, we had to kind of explain the research using very broad concepts. So we just sort of explained that, we were comparing anti-sickness medicines. We know that they work better when they're given together, but they might have more sort of unintended effects. And we use like PowerPoint slides with images and animations and stuff to kind of help explain this, but we wanted it to be sort of as inclusive as possible. So we just kept everything kind of very high level. So we then moved on to the first activity. So the first activity that we did was called Spend Your Motivation. So this was designed to kind of determine the relative importance to people of the efficacy and safety outcomes, as well as the sort of practicalities of taking the intervention. So children and families were given like a number of kind of like monopoly money, and they had to put the notes next to things that they felt were most important. So you can't see this too well, but this here, where we have most notes, is actually the side effects of the antiemetics themselves. So thinking about things like, constipation, diarrhea, some of these side effects can be quite severe. And, I think it's not necessarily what we expected people to find most important. So the next activity was then a kind of number of hypothetical options of taking fewer medicines with a kind of particular probability of not feeling or being sick, and a particular side effect. And knowing this information, people would then choose whether they would sort of have option A or option A plus B. And children and families just tended to pick a middle ground. So yeah, something that would like allow you to kind of minimize the side effects but maximize the efficacy. And this sort of facilitated discussions around this, and we found that in practice children were doing this anyway. They would like modify the number and type of antiemetics they were taking on a daily basis to mitigate against the certain side effects that they were experiencing. There were things around like the fact that obviously the antiemetics came along with side effects, but they also exacerbated the side effects of their other treatments. So, this kind of draws into question whether the kind of clinical trial efficacy is translating into real world effectiveness, as it were. And it also these activities sort of help to facilitate discussion about how this information could sort of best be conveyed to children and families whilst they're receiving treatment, that in a way that would help them to facilitate discussions with their clinicians, with their doctors, about their treatment options. So they felt that like an information leaflet, for example, would be a useful way of doing this. Thinking about the impact that this involvement work has had on the project. So it has guided a number of recommendations. So firstly, sort of the idea of exploring regimens, antiemetic regimens with fewer medicines. So typically the clinical trials have been designed by kind of adding in another medicine into the regimen each time. But this is evidently coming along with adverse effects. So there's potentially a need to see if we can reduce the number of particular antiemetics given without kind of getting a like meaningful reduction in efficacy. There's also a kind of greater need to have individual conversations about what matters to patients when deciding on treatments, because these things are quite individual, and what matters to one child might not matter to another. And then I also mentioned the production of new tools to facilitate this discussion, which is something that we did later on in the project. And then thinking about, if children are concerned about side effects, this really gives weight to trying to identify who is deriving most benefit from the antiemetic regimens, because we want to avoid giving these regimens to the children who maybe are deriving less benefit but might still be experiencing side effects. And we did actually establish that older children gain more relative benefit from these combinations of anti-sickness medicines. So they're actually both more at risk of CIMV, and they derive greater relative benefit from the sort of additional antiemetics. So this has helped to guide recommendations that older children might choose this option from, for example, their first round of chemotherapy, despite the risk of more side effects. Okay, right. Moving on to the animation video. So this was actually my favourite part of the project. It was really nice to have something that sort of pulled it all together. These are actually some scenes from the animation video as well, so you can kind of see how that turned out. To do this, we involve children and families in two ways. So firstly, through an in-person event held at the Candlelighters building in Leeds. So that was part of this established patient involvement group. We involved one child and his dad at this meeting. We had more sort of signed up, but I think it ended up being just like a really sunny weekend, and it's held on. We used to hold them on a Saturday, so I think people just didn't want to turn up that day, which is fair enough. So yeah, this meeting was to help us understand what would be best to focus on in the video. So we showed like some ideas for the video content, which we designed through Canva, and then we kind of asked them, what do you think are the most important things out of this, and what should we be focusing on? And they thought it would be best to focus on how we'd actually involved people, the impact it had had on the project, and then this information about side effects and older children benefiting more. So we kind of took this forward. The next part of the involvement we held online, this involved 3 children and 5 parents. So at this stage, we were designing the video with a company called Nifty Fox Creative. So they work a lot with public sector organisations, and their sort of processes actually make it really easy to involve people. So they designed a storyboard for us that, was kind of informed by our initial piece of involvement, and this helped us kind of get input from children and families on things like the content, visual metaphors, like minor script changes, and what additional information could be included in a visual summary, which we would signpost to at the end of the video. So we only had enough funding to make one animation video, so it needed to be as accessible to like a broader age group as possible. So some of the kind of, I guess, more like complex ideas we held back to include in this visual summary. Yeah, so to kind of facilitate all of this involvement, we held an initial meeting to go through what the involvement would entail. And then we gathered all the feedback on a Google Doc so we could see what everyone was saying. And then we collated the comments and then added them into this this online system. So it was quite easy in that sense to involve people, and you could kind of go through scene by scene and make comments. So the feedback was mainly centered around making the images more reflective of what it's actually like on a children's ward. And again, as sort of statisticians and methodologists, we, very rarely kind of have access to the clinical environment. So I was quite lucky kind of early on in my project to be able to go to a clinic at Leeds Children's Hospital, but this isn't sort of common practice. So, you're very kind of rarely in evidence synthesis having much actual patient contact. So if you think back to this slide, like this was the company's first idea of what the scene should look like, and children and families said, well, this doesn't actually look like children receiving chemotherapy. This is more how adults receive chemotherapy, sort of being sat in a chair, whereas children, younger children are often able to do activities whilst receiving treatment, and older children might be like in a bed playing on their phone, for example. So it just helps to make the images more realistic. And this was the information leaflet at the end which is signposted to at the end of the video. So the involvement kind of informed what was included in this. For example, if you can see the sort of proportion of the side effects versus the benefits, and parents felt like it was important to include the names of the different antiemetic regimens that are available. So it kind of gives a summary of the whole project, but includes these important bits that we were able to identify through the involvement. Okay, and moving on to evaluating the involvement. So after each involvement session, I sent round forms that looked like this, but it didn't really give me a lot of sort of valuable information. I think like these things are often used as a bit of a tick box exercise, and like we wouldn't get them back from every person. So yeah, it wasn't the most sort of useful, I don't think, for getting feedback. I actually got more feedback from speaking to people about their experiences. So some people were involved in like multiple of the involvement activities. So I felt like I got more from them just kind of informally talking about what went well and what didn't, for example, in the next session. I'd always planned to involve someone who was involved in the project in a presentation to disseminate the project findings. So when I had the opportunity to give this talk, I thought it'd actually be a nice idea to involve a young person who had been involved throughout to give their reflections on like their own reflections of what it was like being involved. So I have a video I wanted to show you here. So this this video, it's about 4 minutes long. It's from a young person called Martha, who was involved in interpreting the project findings and making the animation video. And she's also been involved in some other researchers' work, which she sort of reflects on at the end. She wanted to be here in person today, but obviously it's during school time, so we thought that instead a video would be better. A little bit about the sort of ethics of this kind of involvement. So we got consent from Martha and her mum to use this video as part of the talk, and they were happy for it to be kind of recorded and shared as these talks are. And as with others involved in the project, Martha was paid, reimbursed for her time to provide this feedback. So it was like a separate piece of involvement. And she speaks a little bit about the importance of this in the video. So I'm really hoping you can hear this. Do let me know if you can't.
Sorry, Ruth, I don't think I can hear that. I'm not sure if
Can we
I've
not
extended.
hear it?
I don't know. Was there an option to share with sound when you, if you maybe stop sharing and then when you reshare, there's like a toggle for share with sound. If make sure that's ticked on, maybe.
Let's have a little look. Stop share and then share. Include sound.
Include sound.
I think
Yeah.
I've seen it. Yeah.
Oh, great.
Okay, let's try again. Slide. Okay, let's try this again.
Hello, my
Can
name
we
is
hear that?
Martha.
Great.
I am 15
Yeah.
years old and I had cancer treatment when I was 13. Over the last few years, I have participated in several research projects as I want to help make a positive difference to the cancer treatment of children in the future. I am here today to talk about the good things that I have found researchers have done and the things that I am hoping can be improved. The first focus group I took part in was an in-person research group at Candlelighters about anti-sickness medicines and our opinions on the importance of different side effects to do with those medicines. I really enjoyed going to this focus group in person as it made me feel a lot more helpful and involved. This focus group in particular was very interactive and engaging for the wide range of ages that attended. There were a variety of activities to take part in throughout the morning, like a visual task where we were given Monopoly money and told to spread our money out onto photos of different side effects of anti-sickness medicines. The more money you put on an image, the more that side effect mattered to you. This was good as it kept younger children engaged and excited so that the researchers could easily tell what actually mattered to the patient in terms of side effects of medicines. The focus group took place at Candlelighters in the Square in Leeds, so it was comforting to be in a familiar place and see familiar faces. Although it was nice to have a wide range of ages present and enthusiastically taking part, it is always hard being the only one or one of few teenagers there. I know that I felt rubbish when having treatment, so I, like other teenagers in my situation, like giving feedback and opinions to help people in the future having cancer treatment feel a little less rubbish. This is difficult to do, however, when the discussions I want to have are very different to, for example, the discussions 8-year-old boys want to have. I believe it would be beneficial for everyone if researchers went to charities like Teenage Cancer Trust and Teens Unite if they wanted to gather more information from older age groups. Recently, I commented on a storyboard about anti-sickness medicines. In my opinion, this was structured very well, as we had a meeting before we gave any feedback on Zoom to establish what the project was about and how we would be helping. Then we were sent a link and, in our own time, we could comment on each frame of the storyboard. I thought this was a brilliant way to structure the feedback, as it allowed us to take our time and there was no pressure and we weren't put on the spot, so we had plenty of time to think. I also thought that it was a complicated idea communicated in a very easy to understand way. Additionally, we could also see the comments of others on the storyboard on a shared Google document, which I thought was very useful as it allowed us to be precise with our feedback and ensured we didn't repeat others' ideas. I think it was also good that there was a wide range of ages commenting on the storyboard, adults and children, as what matters to adults isn't the same as what matters to children and vice versa. When the storyboard was finalised, after our comments were read and applied, it was turned into a video and I thought it was really nice seeing the finished product and how our feedback had been implemented. I think it is really good of universities to pay children involved, as I didn't have the energy or health for a part-time job when others around me were starting their first jobs. I spent the money on train fare to go to a Teens Unite Traitors event in London, and it was absolutely amazing. So I really appreciate the money, as it allows me to have these brilliant experiences. I only have one cautionary tale from when I assisted in research. Even though this isn't to do with medical research, I think it still applies to any of you looking for honest and informative feedback. The author of a children's book came to get feedback from young people in person about their picture book on experiences with cancer. This was an issue because it was incredibly hard to give my honest opinions when the author was right there in front of us. They hadn't quite hit the spot with the story, but we were all too polite to say it, as it was already finalised and printed. So, my advice to you is ask for feedback on any research or work early, when it is in draft form. I would also suggest anonymous feedback if it is an opinions-based consultation and you want constructive criticism. I really enjoy helping out with research projects, and I hope this has helped you understand them from a helper's point of view. Thank you so much for listening, and if you have any follow-up questions, please let Ruth know and I will get back to you. Have a brilliant day, and I hope this was useful. Thank you.
So I think, yeah, that's a really lovely bit of feedback from Martha there, which I actually just think you'd be unable to obtain from sort of evaluation forms. I think it sort of highlights the benefit of speaking to people and potentially having evaluation as a separate involvement activity. And yeah, like she picked up on a number of quite important points. So having like the benefits of in-person meetings, having engaging activities, safe and familiar environments, for example. But she mentioned this idea of holding separate meetings for children, younger children and older children, which I definitely think that is what we kind of planned to do right from the beginning. And she's right. There's big differences between what older children and younger children want to talk about. I think the difficulty comes in how that sort of bears out in practice, because we had, say, 3 children taking part, I think, in each of our in-person events, and it then makes it quite difficult to split that down into smaller groups. So, she mentioned some additional patient support charities. So I think it really highlights the importance of pushing this like effort to recruit children right from the beginning, and trying to identify through which channels is sort of best to do that. And she also said about the importance of involving children early on and not coming with a kind of finished project that then is quite difficult to give honest feedback about. So yeah, I thought that would just be a nice note to end on, and I hope that kind of gives you a flavour of what I did to involve children and young people in what was quite a sort of statistically complex project. I have a sort of few sort of final reflections of my own. So, I think there are effective ways of reaching and involving children in evidence synthesis projects through, established sort of patient groups and support charities have been a huge, huge help within my project, and I think is a really good way of both recruiting and involving children. It is possible to explain statistically complicated research in an understandable way if you just tend to focus more on the broad concepts of what the methods have helped you to understand, especially when this is kind of coupled with interactive activities. In terms of the benefits, of involving children in evidence synthesis, it can help you to really focus on what matters, potentially across different age groups. So both within aggregate data synthesis and individual participant data synthesis, which can provide like an additional opportunity to request these patient important outcomes. You know, you can identify where the collection and reporting of outcomes is missing in primary studies, and even kind of tailor the evidence synthesis methods you apply to help address the particular evidence gaps. And if these don't help, it can help you to shape recommendations for future primary research. And then obviously disseminating things in a way that's more useful and will actually reach those affected, and then you know, advice on how to do things better next time. So that was everything. I'd be happy to answer any questions if people have them. I'll stop sharing my slides now.
That was amazing. Thanks so much, Ruth. That was such a good comprehensive overview of the project, and great to see how involved you've had PPI and particularly children as contributors. I feel like from my experience there was a lot of things that I resonated with what you were saying, and having involvement at such an early stage and also exposure to the kind of research area that you're in is such a rare thing to have, but is so important and kind of cements the importance of the research, doesn't it?
Yeah, definitely.
So yeah, thanks so much for that. If anyone does have any, maybe 1 or 2 super quick questions, then feel free to raise your hand or put it in the chat. Yes, Sarah.
Sorry, I've someone difficulty taking my mic off. I think this research is great and very much needed, and I imagine you've got that feedback from your PPI group. I'm a statistician and unfortunately have had lots of involvement on the children's ward with my daughter. She is really keen to be involved in research, and as a statistician I want to make that happen for other children as well. I was just wondering what rate you paid them at. Do they get the same NIHR type of rate as an adult would?
So we actually did end up just paying children the same as we would adults. It was quite, because we had like a range of age groups, it you know, I think right at the start we had plans to like pay younger children with either less or, like, you know, sometimes they can get kind of certificates for involvement, for example. But when we ended up running the sessions like together with a group, it then started to feel unfair that we would maybe pay the older children like more of the adult rate and the younger children with less. So in the end we just ended up paying everybody the same, and yeah, it just felt fairer. And you know, like Martha raised the point that, you know, lots of teenagers work obviously, and they might not have that opportunity. So I do think that this kind of stuff does really help in a way that you might not kind of originally think it does. So yeah, we paid everybody just at the same adult rate.
That's the job they'll ever have.
Yeah.
Thank you.
Possibly.
Great. I'm afraid we have run out of time for any more questions, but I'm sure Ruth would be happy to be contacted if anyone does have any follow-ups.
Yeah, absolutely.
And it was great to hear Martha's example as well. So if there was anything from what she raised that anyone wanted to talk to as well. But yeah, I'll just thank Ruth once again for a fantastic talk. And this was our last seminar of the year. So hopefully we'll see you all in the new year when we've got some new dates for seminars announced. But thanks so much, everyone.
Thanks, everyone.
Thanks, Ruth.
Brilliant. Thank you.